Welcome to the NHSNLink, a CDC application for COVID medication data presentation. Today, your speakers will be Dr. Dan Pollock, the Surveillance Branch Chief from CDC, and Rick Geimer, Chief Innovation Officer at Lantana Consulting Group. And with that, I'll hand it off to Dan to get us started.
Thank you, Dresden. CDC's National Healthcare Safety Network, or NHSN as we call it, is an extensible platform that serves multiple purposes. We are the most widely used healthcare-associated infection tracking system. And along the left-hand side of this slide, you'll see the variety of different infection and related events that we track. We're in use in over 37,000 healthcare settings, including acute care hospitals, long-term care facilities, outpatient dialysis facilities, and places such as ambulatory surgery centers where outpatient procedures are performed. Next slide, please. So we have developed with Lantana the NHSNLink, which is the subject of our presentation today. And we are using certain guiding principles in that effort. We are open standards, open source. We are keenly interested in all of our partners being able to play using NHSNLink. We want to encourage a rise to the top. We think NHSNLink will add enormous benefits and raise the bar for surveillance. It's going to lower the burden of reporting and yet can be deployed rapidly. Our methodology leverages open APIs, HL7 FHIR. Our standard use of standard data is very critical. US Core for Data Interoperability figure very prominently in NHSNLink. NHSNLink enables human review of data when necessary. And our purpose here with NHSNLink is to provide a reference implementation that can be used as a model for other vendor implementers, but also to provide NHSNLink in ways where it can be used in its native form. Next slide. Our focus in this presentation will be on inpatient medication administrations. So the what of that is we want to create a vendor-neutral interoperability standard for electronic queries of medication administration data in US hospital inpatient populations and implement using the open source application, namely NHSNLink. Why do we want to do this? Well, because COVID-19 has highlighted the need for efficient, scalable reporting of medication exposure data during public health emergencies. Data from a single source, proprietary vendor, is time and cost intensive and may not be sufficiently representative. We want to understand what's going on in the outside world from our surveillance perspective so that we can provide data for action going forward. And the data that we're keenly interested in are based on surveillance, which has potentially manual implementation, but that's time and labor intensive, and it may not be sufficiently accurate or representative. So we really are focused on using NHSNLink as part of a data automation strategy. Next slide, please. The hows of the medication administration surveillance are a FHIR query of active inpatient encounters for a defined time period, human review of results for data cleaning and normalization as needed, and then storage of results in a secure data repository where they can be used for analysis and action. Next slide. The inpatient medication administrations have a wide use. Public health surveillance for these medications is illustrated by some prior work displayed on this slide. Health and hospital quality and benchmarking efforts are very important going forward as we move into a phase of the pandemic where the availability of medications is not as much of an issue as it was at first. We still have concerns regarding the severity of illness of COVID patients, and medication administrations provide an indirect indicator of the patient severity, as well as provide a means of characterizing severity for purposes of developing predictive models. The data are to be available in public health emergency settings on dashboards used for using the data as well for trends, setting targets for safety monitoring, and uptake of new or controversial treatments. So a way to track what's going on as new medications enter into use for purposes of responding to COVID. And the next slide. So,
yeah, so this is
transition to Rick. Rick, pick it up from here if you would.
Thanks, Dan. So this is a little bit more detail on the how. Basically, as we were starting to look at this use case, we began accumulating a list of data elements that we wanted to capture for further analysis. So those are the items under the left column of this table, things like admission date, patient age, patient, the medication codes and such that they're taking. And then we began doing a mapping to the equivalent FHIR resources to drive the queries. So things like admission date, discharge date, and such, we figure we could pull from Encounter. The patient information we pull out of the patient resource. And then there were some areas such as those that I think were fairly easy, but others that were more difficult, such as we wanted to get medication administration information, but that's not readily available by in EHRs today. Rather, they've implemented the medication request resource, which is typically for orders, prescriptions, and such. But that had the expected information, such as what medication was ordered, when it was supposed to start, what the dose was, and such, the route of administration. So we are initially getting that data where we can by medication requests, but we understand that this is a draft mapping, and when, as time proceeds and medication administration becomes exposed as a queryable FHIR resource, we could move the mappings to there. Likewise, things like the primary diagnosis, we expected, even though the Encounter resource has a basically a pointer to a condition resource for that, we find that many EHRs don't actually implement that. So rather, we are looking for encounters and then looking for conditions, and then trying to align which conditions were entered during the time frame of that encounter. So those are some examples of areas where the mappings need to adjust a little bit to the realities of what's found out in the wild. Next slide. So Dan mentioned the NHSNLink application, and I want to give a brief description of this. So this is meant to be an open source reference implementation for implementing this medication administration use case and potentially other use cases through NHSN. The idea is we would begin with an expected provider environment, which would have an EHR with a FHIR API and OAuth server for authentication, and potentially other systems as well, labs, medical records, clinical data warehouses, where they might have alternate APIs, proprietary APIs to access them. There might be a HSL version 2 interface, or it might be a setup where people at the hospital will just extract records, put them in a CSV format, and push them to NHSNLink. NHSNLink is the stuff in the orange box, and this consists of a user interface which will initially authenticate against that provider environment. It has a FHIR query engine where it will query the FHIR APIs of an EHR to pull out things like the medication request resources, their allergies, patient demographics, et cetera, and a custom query plugin architecture where, again, you can hit those proprietary APIs or potentially accept CSVs and so forth. And the idea is the user would authenticate, then run the queries. They could bring back the results and potentially edit them in the user interface if needed. It can also work in fully automated fashion if we just want to run it on a schedule. And then again, potentially pull data from other systems. And then it would take all that information, run additional logic after it stores it locally. We do store, any data that comes in as FHIR gets stored as FHIR, and any that does not gets converted to FHIR. And then we basically run our logic and create a report that gets submitted to NHSN and potentially other state and local health public agencies. Next slide. And this is just another view of how the application is organized. On premises of the facility, we expect the EHR, the authentication system like OAuth, and other systems there. And then there's what we call a query or query scoop component, which can exist in the cloud or on premises. If there's a need to access data behind a firewall, that's where we put that scoop component, on premises behind the firewall. But if the EHR FHIR interfaces are accessible, from outside the firewall, then that whole system could reside in the cloud. And basically, that's what queries up, scoops up patient data. We do expect that the application needs to be seeded with some patient IDs of interest. And the reason for this is EHRs and the US CDI, US core interfaces right now don't allow sort of system level access where you can query and say, get me all patients with a given condition like COVID-19. So rather instead, we expect to be passed a list of patients out of bound, and then we can scoop up their data from there, evaluate it. We currently store the logic as CQL in a measure resource. And then we can, after scoop the data, we run that logic against it, generate a report, and we can then transform it into whatever requirements are present in the implementation guide. In this case, it would be a composition resource or a FHIR document bundle with other resources. And we can basically take the measure and convert it to that, or just send the measure itself directly to NHSN. At NHSN, there's a FHIR server that is there to receive the resulting reports. And there's also a measure definition server where on launch of the NHSNLink application, we go and we query for the latest measure definitions, value sets, and such. Next slide. Here's a sample output of the query as shown in basically in spreadsheet format. So as I mentioned, it can generate the results in a FHIR measure report and then transform them to various outputs. One output that a lot of the analysts have expressed interest in is just a simple CSV or spreadsheet-based approach. So this shows all the data elements that were listed a few slides ago in a spreadsheet format with their resulting data. So, to show what goes on behind the scenes, let's see next slide. So this is the example FHIR that gets extracted from a EHR and then shared as a FHIR bundle. And in this case, we've got things like lab observations, we've got the medication request resources, patient resources, and conditions, all listed with their various codes, narrative descriptions, start, stop dates, etc. If we advance forward now, we can sort of see the information again present. But I'm also highlighting some areas where we had nulls in the source data. In other words, we queried the EHR and found that for one of the patients there, there's no information about their race and ethnicity. Maybe they refused to state it. Maybe they were unconscious or something on admission, and there's no way to capture that information. So that's kind of typical in EHRs. There's going to be a lot of cases where fields are optional, where you may want them to be required and wish they were there, but they're simply not. So things like the chief complaint, it just wasn't populated in the sample data set that we had. A lot of the medication start-stop times for some of the medication requests simply weren't there because, again, it's a request, not an administration. Maybe the request didn't specify a start date. So all those are some challenges that you need to work through when dealing with real-world EHR data. Next slide. So here's one more example of the output. In this case, sort of rendered in a more HTML-ish view or web-like view. This is how it might appear in a report, for instance. And then I've highlighted some of the key fields like admission date, patient age, sex, etc. So you can see how they appear in the output. And I think final slide. There we go. Dresden, back to you.
All right, thank you. And if you'd like to contact Rick or Dan with questions, their email addresses are listed here, and we will go offline for the Q&A session. Thank you.
Okay, everybody, this is Melinda from HL7, and we are going to open it up for a live Q&A. You all have the ability to unmute yourself if you would like to ask a question, and we do have one question posted in Whova. It's a pretty easy one, so we'll start out with an easy one here. Is the code that you guys showed at github.com/lantanagroup/link?
Yes, that's where I believe where we are posting the core components. Though I don't believe that will be the permanent location of it. This is just during initial development and pilot, but eventually I believe this will be on a CDC Git site.
Awesome. And at this time, I don't see any other questions in Whova, but feel free if anybody would like to ask a question, just to unmute and chime in. Oh, wait, another one just came in right when I said that. What authentication mechanisms are implemented / used by NHSNLink?
We're using OAuth2 for authentication.
Okay. Anyone else? Other questions? Provider or patient or both for OAuth2?
Provider. This is something that's meant to be run by providers at a particular facility, not a patient.
Gotcha. Well, we need to give you guys some harder questions here, don't we?
I can't promise this is a harder question, but I'm curious how, what triggers the provider to run the application? And broadly speaking, like triggering is always kind of or whatever buzzword you want to use for initiating an action is always kind of an interesting thing in a clinical workflow. So I'm curious, like, what induces the provider to run the app, and what are they getting out of it? Is it meeting a reporting requirement? Is it giving them information?
Dan, you want to take that one, or?
Sure. No, it's a good question, Bill. I think the short answer is to meet a reporting requirement. Whether it be COVID, or in the future a healthcare associated infection event, or antimicrobial administrations. Obviously, they're going to go beyond COVID. So the work we're doing now is extensible into the other types of events and processes that are reported into NHSN.
Yeah, and so why not trigger it off an event of some kind as a background?
Well, in essence, it is. I mentioned during the presentation that we need to get past a list of interested patients out of bounds, since basically we don't have the ability to query for the specific kind of information that we want across patients. So effectively, there is, there are value sets. For instance, we're interested in, for one of the use cases for COVID, we're interested in patients that have had a positive PCR test or are under COVID-related isolation procedures. We've created value sets with lists of codes for all of those. And the idea is that there would be some system, at the facility that would be querying for patients that meet any of those criteria, and then it will build a patient list. And when it's time to run the report, it can either be done fully automated, at midnight every day, or it could be a task that a infection control professional needs to bring up the application and run the report manually, and they're expected to review the results and potentially make changes. So there is triggering involved, but there's also the sort of batch, and it's not one-off reports every time a patient shows up with a condition. It's a whole group of patients that will be run and submitted in a single report.
Right. There will be work to enable all of the pieces to run effectively on the sender side.
That makes complete sense. I have a second question, but I'll pause and see if anybody else wants to jump in.
I do have two more in the chat as well.
Yeah.
So let me read those really quick. Is this intended as a push of data to NHSNLink or pull from Link?
It's a pull from the EHR, and then NHSNLink pushes it to the NHSN servers at CDC.
Okay. Is the provider initiation done via a Smart on FHIR module or something standalone?
We're complying with the Smart on FHIR OAuth stuff. Yes, it's not technically a Smart on FHIR app that's launched inside the EHR though. So I just want to verify, though there's one thing preventing it from being such.
And then I have one more in here. What level of de-identification is needed for sending this sort of reporting data?
Dan, that's all you.
Yeah. So, our plans are contingent on some of the end uses of the data. NHSN does share data with state and local health departments that in many instances want PII. NHSN typically does not use PII. So it's a TBD as to whether or not we pseudonymize completely or perhaps explore delivery of some PII to meet certain use cases.
Gotcha. Well, that's time for us right now. I really want to appreciate everyone that participated today, and we got some really great questions. Thank you so much. Thank you to our presenters, Rick and Dan. And if you guys could please remember to rate your session, we would appreciate it. Thanks and have a great rest of the event.
All right, thank you.